Good afternoon. I want to welcome everyone to part 3 of what we thought was going to be a 2-part series, but now we've extended it to a 3-part series on mechanical ventilation. Just to summarize what we've reviewed up to this point, during the first lecture, we talked about the definition and the history of artificial or mechanical ventilation. We also talked about the classification, if you recall, so that we could understand how we got to this point of the conventional ventilation, mechanical ventilation that we see and that we work with. We then talked about physiology, trying to understand a little bit about the gradients that we see within the airway and the various pressures and how they're affected by positive pressure. The focus on this lecture was really on positive pressure ventilation, and in particular invasive positive pressure ventilation as opposed to non-invasive and as opposed to negative pressure ventilation, i.e. the iron lung. We then talked about the concept of compliance and elastance and how you calculate the 2 types of compliance and what it means, dynamic and static compliance, and how we can use those numbers in terms of assessing on a regular daily basis our patients in terms of their lung physiology and whether they're getting better or getting worse, and sometimes it even allows us to figure out where the problem is. Okay? Just remember that you won't always see one pure type of compliance issue. Many times they're combined. And we maybe touched on this just a little bit, but when you're talking about decreases in static compliance, we're looking at things that affect the alveoli and the interstitium, things that affect volume. But things that can also affect airway and volume are entities like pneumothorax, can affect both airway and volume, therefore both compliances will be decreased. Okay? Things like atelectasis or a complete collapse of a lung can also affect both compliances, so you may see them both decreased. Things that affect just airway will usually decrease just the dynamic compliance. Okay? From there, on the second lecture, we talked about the concept of PEEP, or positive end expiratory pressure. We talked about also the concept of auto-PEEP or intrinsic PEEP. Some people call it occult PEEP. We talked about the history of it and how it was developed by Dr. Tom Petty, who worked out at the National Jewish Medical Center in Denver, Colorado, and how we apply PEEP. Okay, and that PEEP really is applied when you have alveolo-interstitial lung disease. It recruits alveoli. That's the answer to any board question that you may see. Okay. We also talked about the complications of PEEP as well as the benefits of PEEP systemically, if you recall. So since it's a preload reducer, patients who have cardiogenic pulmonary edema in particular will benefit from PEEP, okay, because it acts as almost as do nitrates and morphine do on venodilation. Okay. The negative consequences can be when you have overextension of alveoli and causing decreased perfusion in the periphery. So it can cause prerenal azotemia, it can worsen pre-existing bowel ischemia. It can cause increase in intracranial pressure, especially for those who have ICP monitors in place. So those are all things that you may want to consider. It's not just about the lungs when we're applying PEEP and when we're looking at patients on ventilators. Okay. From there, we also talked about the concept of auto-PEEP and how that can develop and how you can suspect it. and how you can treat it. And we talked about the different things about maneuvers that you can perform on the ventilator, with whether it be switching the patient from SIMV, assist control to SIMV, or decreasing the rate, decreasing the tidal volume, increasing the flow, sedating the patient on occasion. And then for those patients who you cannot decrease the PEEP because you need the recruitment of alveoli, sometimes you can calculate the auto PEEP and try to match as close as you can the external PEEP to that. And we talked about why that works. Okay. I did forget to mention that we talked about the different modes of ventilation and what mode means. And just to remind everyone, a mode really defines the relationship that you as the clinician create between the patient and the ventilator, that interaction and how that patient interacts with the ventilator. And if you keep that in mind, you'll understand when you go from controlled ventilation, when you go to assist control, to synchronized intermittent mandatory ventilation, or otherwise known as SIMV, you'll understand what you're doing and what you're changing and how that patient can interact based on their physiology. We also talked about it's important when someone is on a ventilator to try to understand if they have underlying chronic lung physiology, whether it's restrictive, whether it's obstructive, whether it's both, whether it's not, either one. For patients who you're protecting their airway, patients who have seized, who may have normal AA gradients, okay? So it's important to know that and to keep that in mind. We then talked about how you set someone up on a ventilator, and we talked about not only the modes, but we talked about when you're intubating someone, to know whether you're doing the intubation or someone else is, did they see the vocal cords? Because the likelihood of intubating correctly, if they've seen the vocal cords, goes up astronomically, as opposed to, well, I wasn't sure, but I put it in. And so sometimes you can't rely on chest elevation, because sometimes people who are very obese, both their chest and their abdomen will elevate when you're insufflating the esophagus, and you won't know the difference. So it's important, if you don't have capnography available, okay, to measure their CO2, exhaled CO2, which should be elevated in someone who's not intubated necessarily, then, or not elevated, excuse me, but should be elevated when they're intubated. You may not have that ability. So obviously a chest x-ray or reverting back to just bagging that patient until you can make sure that you can insert the ET tube correctly. Place all patients on 100% initially, and one reason is not only because you may not have it in the right position, but it may be also going down one main stem bronchus. And so you're going to be ventilating one lung. And until you can look at that chest x-ray, it's better to keep them on 100%, and then you can adjust based on the position of the ET tube. We talked about how you can tell whether an ET tube is in the right place. You look for that main stem carina, should be about 2 to 3 centimeters above the main stem carina. If you cannot locate the main stem carina, look for that aortic notch. And so that tip of the ET tube should be right at that level of the aortic notch, and you can feel pretty comfortable that you're in the right position. Okay? So today's discussion will be on weaning. And how do we wean? When do we feel we can wean? When is it appropriate to wean a patient from the ventilator? All too often, once a patient is intubated, one of the first questions that a family member might have or another consultant might have is, when do you think the patient can wean? Okay? And so there are things that I want you to keep in consideration, to understand before you feel that the patient can wean. And then we're going to talk about the different modes of weaning. And as I said, I believe on day one that no mode of ventilation has been really shown to be superior to another mode. And I mentioned that there are some pulmonologists who keep patients on assist control. And you cannot fault them for that, because the literature is pretty clear, okay, that SIMV is not necessarily superior to assist control when it comes to managing a patient, unless they develop auto-PEEP, and obviously you want to make changes according to that. But when it comes to managing and extubating or weaning patients, no mode is superior to the other. What it comes down to is one's comfort level in terms of how they've been trained and how they have managed patients, how they were trained to manage patients and wean patients. Okay? So feel free to stop me at any point so we can answer questions. I want all of you to understand what we're going to do and why we're doing it. So, yes?
Can I just ask you something? Can you take the beeper off and the cell phone if you have one, because it's in your ear?
My beeper is?
Yeah, the beeper and the cell phone.
My goodness. I feel like I'm at the airport. Okay. God. Get up to the wall here. Okay. All joking aside, so when you are trying to decide whether a patient can begin weaning, obviously you're talking about patients who have been on a ventilator for a particular amount of time, and that time can vary. We've had patients who we've weaned and extubated within 24 hours and even less than 24 hours based on what they were intubated for, whether it be usually a drug overdose or a seizure, and then they wake up and they're fine and hemodynamically stable. They have nothing intrinsically going on with their heart or lungs, and so they can be extubated in a very short period of time. There are other patients who obviously have been on the ventilator for days, weeks, even sometimes months. And so those situations call for really understanding when the patient is ready, and it's based on multiple factors that you have to take into consideration. So one general concept that I want to get across to you today, being young and starting to learn about this, is that before you can actually wean, okay, and hope to extubate, okay, unless you're withdrawing care, okay, the patient must be awake, alert, and following commands. Okay? They don't have to be oriented, but they have to be awake and alert and following commands. Okay? All too often I've been called, and Dr. Perlman knows, we've all been called to come because patient is unable to wean, and the first thing I do is I walk into the room, and you'll see the propofol running, the Ativan or Versed running in an infusion, and it's pretty clear why these patients can't wean. Okay, it's pretty clear. So just remember that. Okay, they must be awake and alert and able to follow commands. The other concept is try and figure out why they got intubated, and if so, did we correct that problem? Okay, so pneumonia, pulmonary edema, whether it be cardiogenic or non-cardiogenic, severe metabolic acidosis in the setting of chronic lung or heart disease. So patients who come in florid renal failure have a metabolic acidosis, especially these elderly patients, and they've been acidemic for quite some time. It has nothing really to do with their heart or lung, but they may have also concomitant left heart failure. They may have concomitant COPD, emphysema, or interstitial lung disease, and that work of breathing tired them out to the point where they couldn't maintain good ventilation and they got intubated. So did you correct what caused them to be intubated? It wasn't necessarily the respiratory insufficiency, but it was the respiratory insufficiency which developed because of the persistent metabolic acidosis. Whether they're septic, whether they're on pressors, very important. If they're still on pressors and they're septic, it's not a good time to extubate. It's not a good time to wean, okay? Patients who have had surgery, especially abdominal surgery, because the closer you get to the diaphragm in terms of surgery, the more difficult it is for that patient to maintain their normal work of breathing because they're in pain and they're not going to be able to create the excursions of their diaphragm that allow for normal mechanical ventilation. And I'm trying to emphasize this because you must understand that it's not just about the numbers. It's not just about the pH and the PaO2 and the CO2. It's also about the work of breathing, the mechanical factors in ventilation. And you must take that into consideration. Why? Because there have been some patients that we have in the ICU who have been on steroids, systemic steroids. They have been on steroids with aminoglycosides. They have been on steroids with or without a paralytic, okay? And therefore they can develop neuromuscular weakness, ICU myopathy, okay? And it's important to remember that and to understand that, okay? Also, I try to teach the residents and students when we're weaning and then extubating a patient, especially when you're weaning, if at all possible, sit them up. Sit them up, okay? Because to try to wean someone who's lying down, you want to give them every benefit, okay, that they can to get that diaphragm working. And so if you have an obese patient who's lying down, the abdominal contents is going to push up on that diaphragm. Therefore, their excursions are going to be less because they're going to have a increased work of breathing. And so you want to help them out in any way you possibly can, especially for your emphysema patients. Okay, your emphysema patients don't do well trying to breathe with their diaphragm in this position. They do much better when they're up. In fact, I've taught some of you that a lot of emphysema patients will lean forward because now the fulcrum is here. It's no longer at the diaphragm because that diaphragm is being pushed down by the bullae. And therefore the Starling curve now, the diaphragm has gone out this way and there's not that optimal position of those myofibrils to contract. So it's important to always take this into consideration. Okay, plus patients want to see. Remember, remind them in the ICU where they are, what day it is, how long they've been in there, you've been in touch with their family. They don't know, okay? And I learned this from a very personal experience when my father had open heart surgery and they had me see him in the ICU and he was intubated and he was trying to communicate something to me and I was trying to guess it and I could see he was getting frustrated. I couldn't figure out. And really what he wanted to know was what time it was. What time of the day, what date is it, how long have I been here, how much time has expired. And so you can really decrease a lot of the anxiety. And some of you have heard me talk to patients right up to their ear and say, sir, you're at Atlanta Medical Center, you're in the ICU, you've been here for 3 days, today is August whatever, it's this time of the day, we've been in touch with your family, so, and the good news is we're going to get you off this machine. Okay, this tube is in your throat because you need a little help to breathe, and you explain things to them because they don't know. They lose time of day, months, hours, they don't know. Okay, so try to decrease any potential for anxiety in these patients, okay? So, very important. All right, so when you're with a patient who is on assist control, and we're going to go through the different modes and see what you can do to wean patients who are on the different modes, okay? As we mentioned, you're going to set a frequency or a rate, right? They have a set tidal volume, a set FiO2, plus or minus PEEP, okay, depending upon what you're treating them for, okay? And you want to make sure, as I said, that they're not being sedated, that they're awake, alert, you've corrected whatever got them on the ventilator. You make sure that their electrolytes are corrected, meaning the most important ones in this case are potassium, magnesium, and calcium, as well as phosphorus. And once you do that, you also want to make sure that they're if they suffer from any protein malnutrition, that you try to correct that. Doesn't necessarily have to be corrected because it takes a while. We usually follow prealbumins in that regard, and sometimes we can correct them pretty quickly. Other times we can't, but keep that in mind. Nutrition is so important, okay? And in your patients that have COPD or CO2 retention, those are patients that you really want to pay attention to, because not only do they have protein malnutrition, but high carbohydrate diets can make their work of breathing worse because of what is produced is CO2 from carbohydrates. So you want to be careful with that, okay? All right. So if you have someone on AC, as we mentioned before, this is assist control. And when you're looking at the graph, the waveform, I should say, the assist control, you see these types of waveforms, where the area under the curve is the tidal volume, and this is the rate, okay? It allows the patient to take an inspiration, and then it gives them a machine breath, which is the full tidal volume where the machine is set. So what can you do when you have someone on assist control? Well, there are times, and I'll tell you this, that I have just gone right from whatever they're set and just taken the tube right out. And usually I'll do that in someone who's young, who has no underlying cardiopulmonary disease and was intubated for a non-cardiopulmonary issue. Typical one would be a drug overdose. I won't wean. My weaning is just I see them, I look at them, and if everything looks good, their blood gas is fine and they're awake and alert. Usually what they'll have had, as I told you before, they'll have an abnormal blood gas when they get intubated, but usually the gradient will be normal. So you know that this is all neuro, central, and it's corrected now, and you can just take the tube right out.
Does it matter how long they've been intubated for?
No, you know, usually those patients who reverse real quickly, you know, it's 24, 48 hours and I'll just take that out, okay? In other patients, and these are the majority of the patients that we see, are the ones who've been on the ventilator for 3, 4, 5, 6, 7 days, who have underlying chronic heart disease, lung disease, kidney disease, and may have also on top of that a pneumonia or pulmonary edema. Those are patients that you go a little easier with, okay? And so what I usually like to do is decrease the rate first. And the reason is that you want to try to allow them to take more breaths. So usually they'll be breathing at 12. So if you decrease the rate to 6, allow them to take, and you'll see there'll be more breaths. There'll be more breaths that they're taking, okay? And you can see how they're doing and look for their rate, look for their minute ventilation, which would be the rate times the tidal volume. Depending upon the size, okay, of the patient, minute ventilations, and depending upon whether they have underlying lung disease, whether it be COPD, emphysema, restrictive lung disease, the minute ventilation can vary anywhere from 5 to 6 liters per minute, which is usually what we're breathing at, up to maybe 13 liters per minute. When you get beyond 13 liters per minute, usually those patients are not yet ready to come off. But what you need to do is look at them. It's not about the numbers. You want to look at their work of breathing. So if they are using their accessory respiratory muscles in a COPD emphysema patient who got admitted for an exacerbation or for wheezing, that patient isn't ready to come off yet. They're already using their accessory muscles and you haven't taken the tube out. So don't, even if the SAT is 99, please, okay? Even if the SAT is 100, if it's 199, doesn't help me, okay? Take the SAT and put it away. I know a lot of people will tell you, Dr. Lovett, you know, the SAT's 90. I understand that. I understand. Put that away, okay? We don't use SATs in the ICU for this kind of issue. Look at their work. If they develop paradoxical breathing, or if their wheezing gets worse on the ventilator while you're decreasing their rate, That's telling you they're using more and more effort. They're just having a hard time. They're not ready to go. They're not ready to go. So back off. Assuming that they are doing better, okay, you can get down to a rate of 6. At that point, you've got to make a decision. If they look really good and you can get a blood gas, because I really recommend getting a blood gas before you extubate, especially for patients who got intubated because they had an exacerbation of COPD, or they had an exacerbation of asthma, or they had pulmonary edema. I think it's important, because if their rate goes up but you get a CO2 that comes back at 40, that may not be okay for you. That's relative CO2 retention. They may not be ready, okay? They may not be ready. So you've got to put everything, there's no magical formula, but it's parameters to take into consideration, to look at before you think you can pull this tube, okay? Because what really makes it more difficult is when they give you that patient that they said, well, we've made them DNR or A&D with no reintubation. So now it's all on you, okay? They get one shot, right? Because now you've extubated, can't reintubate, right? Because they've said that. I try not to get into those situations, and I usually tell them I'm not going to accept that, because that's something that I can't guarantee. There are too many variables that can influence, and I think it's double jeopardy. I think you're putting the patient as well as the physician in a very difficult situation, okay? So decrease the rate. Once you get to 6, 5, it doesn't really help to get any lower than 6, really, because we don't breathe like that normally anyways. So take a look. You know, if they desat on you right away and that, well, you know they're not ready to go. Or they have the increased work of breathing, you know they're not ready to go. Yes, Dr. Perlman.
The advantage of switching to IMV for seeing their work versus, I know there's no
Yeah.
standard,
Yeah.
but, or decreasing assist control rate.
Yeah.
Why not go to the more work mode?
I agree. I agree with you 100%. The problem is I've got to present it this way because it's never been shown. It's never been shown to be superior. But yes, we'll get to that, and you're absolutely right. That's how I was trained. That's how I like to do it, and it makes sense physiologically, the SIMV, and wean the rate down. Yes, I fully agree. Now, go ahead. Go ahead.
Well, I wanted to give you a second question. So if you
Okay. What some people do at this point, when they get down to a rate of 6, is one of two things. They either feel very comfortable and they know the patient, they say, listen, this patient's ready to go, I got the blood gas, it looks much better, no CO2 retention, their oxygenation is better, their work of breathing is good, extubate. Okay? Others will say, you know, everything looks pretty good, but still this patient's very tenuous, they're very thin, they've lost a lot of weight, they're weak, I just want to make sure. And what they will do is they'll go to something called a T-piece. Okay? So what a T-piece is, if you have, what they'll have is, here's the ET tube, and the ET tube is connected, okay, through a little apparatus that allows for oxygen to be blown through here, okay? And the patient then can take their own oxygen, not through pressure, but the ET tube is still in place, but they have oxygen, and you see how they do. And it's almost theoretically that they're off the ventilator. They really are off the ventilator, but you still have that ET tube placed in place. So one of our pulmonologists here likes to do that and use it, and it makes sense. And you can do that. You can actually put someone on a T-piece. Now, what is the disadvantage to the T-piece? Well, couple. One, no matter what you're doing, this is all dead space. So they're breathing through dead space. If they already have pre-existing dead space, it may become more difficult. And what they may have to do is increase their rate, which they're only increasing their rate not because they're not doing well, really, but because they have to suck through this tube. It's a straw, okay? The other disadvantage is, and this happens often, if you have someone who is 6'2", where they should really be having an 8 to 8.5 centimeter ET tube in, and they only have a 7 or a 7.5, you can imagine that it's even thinner. And so to get the necessary ventilation in is going to take increased work of breathing. And so you may not know, is it their increased work of breathing, is it because they're not better yet? Or is it because they're breathing through a straw? And so there's where your clinical judgment has to kind of take place, and then you have to make that call. But this is what some people will do with AC. Okay, they'll even do it with SIMV, but most of the time you'll see AC. For some reason, I don't know, the AC people go to T-piece. Okay, I don't do T-piece, but I can't argue if you do. Okay, I can't argue if you do. Does that make sense? Okay. Okay. All right.
Second question.
Yes, Dr. Perlman, yes.
So, one of the things on these trials that try to compare different breathing strategies was at least in one paper, doesn't mean it's the truth, that
Yeah.
spontaneous breathing was a good idea.
Yes.
So, even if the patient is not ready for weaning, and this
Right.
is before weaning, is it worthwhile, even in your sickest patients,
Yeah.
with assist control, to give them spontaneous trial every day? And
You-
what is the point if you're not?
I agree with that. What is the point? It's almost as though it's a way to track when you start thinking that they're getting better. Okay? When you're looking at rate over tidal volume, or you're looking at FiO2 over rate, whatever you may be looking, whatever parameter you're looking at. This is what Dr. Perlman's asking, and he's right. I mean, some people recommend that. In fact, if you look at and listen to some of the big names in mechanical ventilation, like Marino or Dellinger in Chicago, or Hall in Chicago, Martin Tobin, who's at Loyola, these are huge names in mechanical ventilation. Some of them, on a regular basis, check these for spontaneous breathing and see if they're getting better. Others say, why do it if you know clinically that you haven't reversed what you're supposed to reverse? You know, on day 1 or day 2 of a trilobar pneumonia, what is the chance they're going to be extubated? So why do this? You're absolutely right. Some people just say, I like to track it because it gives me an idea if they're getting better. Okay. I just think there are too many variables, not just about the pneumonia, that influence whether someone can get off the ventilator, especially in our patients, because these patients who get pneumonia are usually patients who are diabetic, who may have renal insufficiency, who have protein malnutrition, who haven't been out of bed or out of the house for whatever, and they're deconditioned. And when you give them an infection or pneumonia, it's more than just the hypoxemia caused from the pneumonia that's going to influence whether they get off the ventilator or not. Does that answer?
Yeah, and when you say spontaneous, just to clarify,
Right,
you're
right.
saying literally putting them on a CPAP mode.
A CPAP mode. So they get, right?
Yeah.
That's right. They get just the CPAP, the pressure support, but they get 0 rate. Okay, so anytime they take a breath, it's supported by pressure support, but there's no set rate. It's all on them. It's all on the patient. Is that?
If you do daily trials like those, but you know that the underlying condition isn't really treated yet, and they will have to go back on AC, would you
Yeah.
still mean the probe will fall off, or do you just leave it on?
Yeah, I mean, I think the answer to the question is yes. If you have someone on sedation, you have to ask yourself, well, why are they on sedation? Why are they requiring pain medications like morphine? I'm just making some things up, or fentanyl. Okay, why? Is it because they just had their abdomen splayed open because of surgery? They had bowel obstruction, or they just had open heart surgery and they've got a sternotomy? Is that why? Well, if it is, then you're not going to get them off the ventilator just because of a mechanical problem. So I don't wean anything. I just say stick with it until, and then maybe after 2 or 3 days, I'll switch them over just to see what they can do, okay? To see and then find out, are they requiring, because most of these patients are awake, or their medications are stopped to allow them to awake, because that's what they should be doing on these patients that are on continuous infusion of fentanyl or Ativan or Versed. And then they are asked, where's your pain? You know, if they're still having a lot of pain, you have to go by that, because that really influences whether you're going to be able to start weaning or not.
She's saying take off the sedation during that actual spontaneous trial.
Yes. It is reasonable, and that's another argument. That's a good point that you bring up. And that's another argument. Yeah, if you really want to know, you should stop their sedation. I don't bother with it. I know I'm not going anywhere with this. It's not really going to give me. My feeling is if I have to know if they're getting better every day just by spontaneous, looking at their spontaneous ventilation, I'm missing something, okay? You should be able to first look at, have you corrected what needs to be corrected? 2, are they awake and alert? It goes back to what I said before. Can they follow commands? If they can, then you can begin. If not, you can't. It's as simple. Sometimes it's straightforward, sometimes it's not, but I think in this case, to answer your question, no, I would not. But if you're going to do it, yeah, you should stop sedation to allow them to wake. Absolutely.
And Dr. Love, just on that point, when he's ready to be weaned and you start the AC mode, you decrease the rate.
Right.
For how long do you wait?
You know, there's no set time. You know, you'd like to see a couple of hours at least. You know, you want to see a couple of hours. I mean, what was really helpful is after you've decreased it, if they go spontaneously and their work of breathing increases within minutes, then you stop. You don't wait 2 hours. Even though you may have written it for 2 hours, you stop. You already know the answer. You know that's why I don't leave usually the bedside. I'll decrease the rate and I'll watch them for a few minutes. Maybe go see another patient in the ICU and then come right back and see how they're doing. To answer also further your question about sedation, these patients who are obese or these patients who have renal insufficiency or hepatic insufficiency, these sedatives do not leave their metabolism. So you may stop it now, but it may take several days before you can actually wean them. So another reason why I don't do that. I really don't. I don't approach it that way. It doesn't help me because you can say I stopped sedation. No, you didn't. I mean, you stopped it, yes, but they're still, I mean, the patients that Dr. Perlman sees, if you give these patients, 2 milligrams or put them on Ativan infusion with hepatic insufficiency or whatever these, morphine, they don't wake up. Okay? The same ones with our obese patients where these metabolites accumulate and stay in their body for a long time, it takes a while before they wake up. Okay? All right. So now we go to SIMV. So synchronized intermittent mandatory ventilation, and I showed you the waveform on that. Basically, again, you have a set tidal volume with a machine set breath with the area under the curve giving you the tidal volume. And they can go along like this. When they take their own breath, and it's noted by a negative inspiratory effort, right? What the machine does, instead of assist control where it gives you the set tidal volume, now the machine says, come and get it. You take your own tidal volume. Whatever you can bring in and inspire is yours, okay? And so you may see a change in their tidal volume depending upon how much they can take in, okay? That's where we give pressure support. The pressure support is given for this. So you decrease only resistance in pressure support of the airway. Remember we talked about the transpleural pressure and the transairway pressure? That's what it affects, okay? Therefore, the answer to the board question is it does not affect oxygenation. It affects work of breathing, ventilation. So you're going to look at their CO2, not their O2. Okay, and that will help. Yes?
You may have done this last lecture, so you don't
Yeah.
have to go over it again. How do you personally determine the pressure support?
Yeah, we did. Yeah. So the way you do it is you calculate the resistance, which is the change in pressure over the flow. So in this instance is you're going to look at the pressure with air movement, which is the PIP, peak inspiratory pressure, okay, over the flow, which in this case will be the flow that's set. So it's either 40 liters per minute, 60 or 100, okay? And that will tell you how much pressure support. So it's really the change in pressure. So usually there's PEEP involved, okay? And then the flow. And that number is the pressure support that you add.
Is it minus PEEP or minus plateau?
I'm sorry, did I? I'm sorry, not peak, plateau. You're right. Okay, because it's that graph that I showed you, right? This is peak inspiratory pressure, this is the plateau, and the difference between here is the resistance. Okay? You're absolutely right. So that will give you the what the pressure support should be. Okay? And we're going to talk about how to calculate rate and calculate the tidal volume to the CO2 that you want. Okay, in a minute. I just haven't gotten there yet. So what you're going to do here then is you're going to do the same things that we just said. Did you reverse what the patient came in on? Are they awake and alert? Are they off sedation? Off paralytics? Electrolytes are fine, protein, their nutrition is fine. If so, then what you can do, since you have a rate, a tidal volume, an FiO2, a pressure support, plus or minus PEEP, usually PEEP, okay, is you can first, there are times when I'll go right to zero rate. Go to zero rate with just pressure support known as CPAP, which means continuous positive airway pressure. So there's a positive pressure both in inspiration and expiration. So inspiration comes from the pressure support, expiration with the PEEP. So that's continuous positive airway pressure, CPAP. And sometimes I will go right to zero rate, and see what they do. When do I do that? When the patient is completely, fully awake and alert and ready to go. They did a study, early 90s, determining whether or not patients were better predictors versus physicians better predictors at when they should be extubated. And the patients who self-extubated were better predictors than when a physician thought that the patient could be extubated. Okay? So keeping that in mind, when you see this sign, when the patient's doing this, okay?
Or if they're texting while intubated.
Right. They're ready to go. Okay, they're ready to go. Okay, I remember, just to give you a real quick short story, I was a fellow, and during my residency and fellowship, I stayed in what was like a dorm. I had my own apartment. It was next to one of the hospitals where I rotated all the time. So at least with one of the hospitals, I could just walk out, literally fall out of bed and be there at the hospital. So there was an emergency that they lost power, and they ended up losing temporarily backup power. So they sent a mass tech or page. We didn't have techs in the page. And I woke up and I called and they said, can you come right away? Because we need people to help bag these patients, right? So, I run to the ICU and I see one patient who's bagging himself. So one of the residents is going there. I said, he's fine. He's fine. Continue the bagging. And we went to those patients who obviously couldn't. So when you see that, just remember that story, okay? That's a positive predictive value right there. That one's very positive, okay? He's bagging, doing well, keep the rate, you're looking good, okay? So, sometimes I'll go to zero rate, sometimes I won't, especially if patients have had restrictive type lung disease, whether it be multilobar pneumonia, on top of obesity, on top of interstitial lung disease, and their rates have been high, we're talking 15, 18, then what I do is I try to come down very slowly on the rate, okay? I come down slowly on the rate and see how they do. Keep the tidal volume the same, okay? And if they are doing well on that as I come down on the rate, when I usually get to about a rate of 10 or so, then what I'll do is I'll just go to zero rate. There's no formula about this, this is just my style, but what I'm trying to show you is that come down slowly on these patients, see how they're doing. If they're still looking good, their work of breathing is looking good, their minute ventilation, remember their minute ventilation is going to be a little higher. because their minute ventilation has to be higher. They have small volumes and a high rate to maintain a good minute ventilation. If they're looking good, then what I do then again is start decreasing the pressure support. So if they're at pressure support of 20, I'll go to 15. See how they do for a few hours. If they're looking good, everything, I may go to 10. Then I may say, fine, this patient has been here now for 3 weeks on a ventilator. I'm in no hurry. They didn't get sick and this didn't happen overnight. They're not going to get extubated overnight. So then go back to the regular settings. This is where I differ from other doctors. They may just keep the patient either on CPAP pressure support, so you're breathing through that tube. I don't do that. My feeling is let them rest, because you're going to be sucking through a straw all night. Okay? And they are very tenuous as it is. Why do I need to make them work? I want them to be able to sprint when it's time to sprint. In order to do that, you got to rest them. Okay? You've got to rest them. So I rest them back on their previous settings. The next morning, I don't start weaning. I go right to pressure support of 10 to see how they're doing. And then if they're doing well with that, then what I do is I put them to 0 rate and I start weaning the pressure support. Now, the literature is very clear about this. Patients who tolerate for several hours, whether 2, 3 hours, on a pressure support with 0 rate, CPAP of 7 or less, should wean and should be extubated. That's the literature. That's the data. Hasn't changed. Hasn't changed for a long time. Okay? So I feel pretty comfortable in documenting that and saying I think it's reasonable. We've corrected everything else. Given this, I always document in the note, and this is important for you when you're weaning. Explain why you're weaning. You're weaning because you feel the patient is ready to wean based on we've reversed their pneumonia, we reversed their pulmonary edema, we reversed their wheezing, their whatever it may be. Electrolytes are normal, they're awake and alert, okay? Following commands, okay? Sometimes you don't even have to put down that their ABG is better. You've already explained it. It's better. Everything is better, okay? And then you go ahead and then you document that you feel based on this that you can extubate. After you've extubated the patient, obviously you're going to follow them. You're going to put them on some supplemental oxygen. Some patients you may want to put them on CPAP or BiPAP, okay? Especially if the very obese patients who have restrictive physiology or who have CO2 retention naturally, they have chronic CO2 retention. Yes?
And who else do you need besides neuromuscular patients? Who else should you definitely do weaning parameters?
Weaning parameters, oh, your emphysema patients. Your emphysema patients. And what I do on those is, there's a couple things. On the patients that are very obese and the ones that have COPD emphysema, I put them all on BiPAP right after. Why? A couple reasons. One, they still need some help. They're in that sitting position. They don't have the ability to have full excursions of their lung. They're tired, okay, and I want to ease them into it. I don't want to just say, now you breathe on your own, okay? And so there's a physiological reason that I do that. In patients who have had pulmonary edema, okay, with or without COPD, emphysema, before I extubate them, I give them one more dose of Lasix. Why is that? Because what did I tell you about the positive pressure? What does it do? It causes preload reduction. Well, if you take that positive pressure out, that preload now comes right back in, and I've seen them go right into flash pulmonary edema. So that's why I give them a dose of Lasix and I put them on BiPAP. So they still have that pressure and that preload reduction. Okay? Even patients who are just wheezing, okay, I put them on BiPAP to help them, ease them into it. So you can, I usually do a couple of hours after they've been extubated, okay, and then at night. So you have them stay off a couple of hours just to feel a bit better. They're not on that machine the whole time, okay? And then during the night. The next day you reassess and you look at their work of breathing. You can tell. When you walk in, you can tell right away how they're doing, okay? So I like to bridge CPAP and BiPAP with mechanical ventilation. I do it a lot. One, because one of my attendings taught me mechanical ventilation, but taught me also non-invasive CPAP and BiPAP, and I just did it as a resident, as a fellow, and felt really comfortable with it. And you know, the French, if you look at the French studies, they're very good at non-invasive positive pressure ventilation. They've really figured it out. They know all the data, looking at patients in the ICU and heart failure. It all comes from them, and they do it, and they do a very good job of it. So I tend to follow also their guidelines and what they've done. The other thing that I want to say is when you're looking at extubation or weaning, if someone is still on an FiO2, usually a greater than 40%, unless you know that they have end-stage fibrotic lung disease, severe pulmonary hypertension, and they were desatting even before they went on the ventilator, you really don't want to start weaning. You want to get patients to 40% or less because their requirements are going to be too high. And you need to figure out what is the cause of their hypoxemia. Is it hypoventilation? Is it VQ mismatch, high or low? Is it shunt? What is the cause of their hypoxemia? Okay? And is this acute on chronic? Is this now all acute? What is it? Okay? So it's really important to look at that also as a parameter. Does this make sense? Okay. One of the things that someone asked me one of the residents asked me, the intern asked me, and I don't know that I understood him at the time, but when I went home I kept thinking about his question because I felt that I didn't answer it correctly. And then I think I understood what he was trying to ask me, and that is, but that was going to come with this, only with this lecture, weaning, and that is, how do you determine, just like Dr. Perlman asked me, how do you determine to calculate someone's pressure support? Well, it's based on the resistance. So the change in pressure, in this case, PEEP, the peak inspiratory pressure minus the plateau pressure over the flow, okay? But sometimes you want to know, well, okay, someone's CO2 is elevated. What do I do? Do I increase the rate? Do I increase the tidal volume? Do I decrease the tidal volume? Do I decrease the rate? What do I do? Well, again, it's important to try to figure out why they have CO2 retention. Okay, why do they have, is it all about dead space or is it just hypoventilation? Okay, so if you can figure out, do they have obstructive lung disease, restrictive, do they have a combined, are they a sarcoid patient and now they have both obstructive and restrictive type physiology? Are they obese on top of that? Okay, then you can determine whether you're going to increase the rate or the tidal volume. Now, when we're talking about tidal volume, we talked about that when you looked at the ARDS NET trial that was done 7, 8 years ago, I think, what it clearly showed was lower tidal volumes, set tidal volumes, that is 6 to 10 mLs per kilogram. Patients did much better than those with higher tidal volumes, meaning 10 mLs or greater. When Dr. Perlman and I trained, 10 to 15 mLs per kilogram were kind of the norm. Everyone got 10 to 15. Would you agree? Pretty much 12, 13, okay? And so with this ARDS NET trial, most of it done at the National Jewish, where ARDS was coined and really thought about and described, 6 to 10. So taking that into consideration, if you have, and I'm going to give you now an example, if you have, depending upon someone's restricted, if they have restrictive physiology or not, will determine whether you're going to go with higher tidal volumes or you're going to increase the rate. So I drew up a couple example cases of cases that I've kind of had. I was trying to remember their height and weight. I think I got it right. And then I'm going to put them up here for you, and then we're going to go through how to calculate what rate you should put someone on or what tidal volume you should put someone on based on their CO2. So when you're looking at CO2 and you're looking at alveolar ventilation, basically, this formula is what you're going to okay. So this is just the basic standard formula looking at assuming that the dead space ventilation stays the same. So this can change if you have someone who has worsening pneumonia, for instance, or they're continuously throwing PEs or something like that. But usually in our patients are kind of stable. So assuming that the dead space ventilation doesn't change, it's your known PCO2 times known alveolar ventilation is equal to what your desired CO2 is times the desired alveolar ventilation. Okay? So, keeping that in mind, if you have, and I came up with a case that I kind of made up, you have a man who is 6 feet 2 inches, okay, and 190 pounds. So therefore, about 81 kilograms, okay, is on a set tidal volume of 600 mLs, okay? And his rate or frequency is 10 per minute, okay? And I came up with a pH of 733 and a CO2 of 60. So what would you do to determine whether you're going to change the tidal volume or the rate to correct that respiratory acidosis that the patient has? Okay.
Is he on CIS control right now?
Yeah. Yeah. So, and that's why they call this always the exhale tidal volume, because you know that it's the tidal volume that they're getting. They're pretty much equal. So if you look at his weight and you compare it to the tidal volume that he's getting, we're kind of giving him kind of a low tidal volume, right? A lower tidal volume. So you have room to go up on the tidal volume, and that's where you would want to go. You would want to work on the tidal volume. So having said that, and keeping that other formula in place, what you want to do is, excuse me, is the desired PCO2 is going to be equal to what the known CO2 is times the known tidal volume over the desired CO2, okay? And so if we take those numbers, basically what you're going to have is 60 times 600, which is the mLs, right, over 40, and that's going to be 900 ml would be what his tidal volume should be. I think this is what the intern was asking me, and he's not here today, and I'm sorry, but maybe one of you can relay that to him. No. Yeah, I think he asked a very insightful question, and I didn't really understand it first, but it would have been anyways part of this lecture and not the other one, but it just worked out that way. So okay. So does everyone understand this?
So this is tidal volume.
Right. The tidal volume, desired volume, is 900 based on this formula. And I use this once in a while. Some of us can kind of eyeball it already because we've done it so many times. But this is really the technical way, the accurate way to do it. Okay?
Why would we not increase the rate? I know there's room to go up on the tidal volume.
Right.
But how do you decide if you want to do that first or if
Yeah.
you move on to
Yeah. Well, there are several things. One, remember when you're increasing the rate, You're also increasing potentially work of breathing. And you're also, if you are underventilated with a lower tidal volume, there's a tendency to develop also atelectasis with increasing the rate, okay? And so if you don't have to increase the rate, you'd rather go up on the tidal volume, especially in a large man. He's greater than 70 kilograms. These people need more volume.
That would not apply to somebody who has ARDS, right?
No, exactly. That's why I quoted the ARDS net trial, and absolutely. In fact, what would you say then? This goes back to the argument, the discussion that we had on, I think, day one, the permissive hypercapnia, right? And why do we call it permissive hypercapnia? What are we actually doing? Yes, we're saying we're going to accept a pH of 7.22 or 7.21 with a high CO2, but what's the reasoning behind it? Does anyone remember?
Because it's always about the forward flow, so we need the curve to go to the right because we will get more oxygen to the tissues, which is...
Right. What you're talking about oxygen delivery, right? So what you want to do is, by creating an acidemic environment, the tendency of hemoglobin to release oxygen to the tissues, which usually in ARDS is a big issue, right? Big issue. So that's why you would do that. That's the concept behind all of that. So that is completely different than what we're doing here. Here, you're not dealing with ARDS, obviously. You're going to be dealing with, I'm underventilating this patient based on his weight, based on his pH, based on his CO2, and I need to correct it. Now, what am I going to do? Am I going to increase the rate? Am I going to, okay, assuming that he doesn't have a restrictive physiology, obviously, okay? Okay. So let's go to the next example that I drew up. I just tried to get these numbers so that they would coincide for us, so that's why I wrote them down so I could. So you have, excuse me, you have a woman who is 5'2" and she's 115 pounds and 52 kilograms.
None of these patients are at Atlanta Medical Center.
Right,
Sorry.
right. Okay, you're right. She's on a respiratory rate of 7 per minute, 7 breaths per minute. And her tidal volume is 800 mLs. Her blood gas shows a pH of 728 and a PCO2 of 58. She has no metabolic acidosis, purely respiratory, okay? So what can you say about this individual? Well, one, you could say that maybe we've maxed out and gone even above a little bit in terms of the tidal volume when we're looking at mLs or cc's per kilogram. Would you agree with that? Right. And that she's on a rate of 7 per minute. So you probably have room to go up with in terms of the minute ventilation by affecting it by increasing the rate. So how would you do that? Well, it's the same what we did before, and that is, so you looked at what you want as your desired rate or frequency is going to be equal to the known frequency times the known CO2, PaCO2, over the desired PaCO2. So just to expedite, I wrote this down, it would be 7 times 60 over 40. Therefore, it comes to about 10.5 breaths per minute. I just rounded it off to 11 breaths per minute. And if someone would like to share this with, yeah, I'd appreciate it. I was hoping he would be here, but his question was very appropriate, and I just wanted to make sure. And he'll see it on YouTube. Okay. So, with regards to weaning and extubation, to summarize, okay, it's very important that before you make that decision, okay, unless the patient you're going to withdraw care, they've been made an A&D and are comfort measures, okay, you really want to make sure that the patient is awake, alert, and can follow commands. You want to make sure that you've corrected whatever caused them to be intubated, and you want to make sure that they are sitting up, that they're off sedation, their nutrition is being addressed, their electrolytes are in order, okay, especially phosphorus for ATP development, right, for that muscle to work, to contract, okay? And then you have options. Options meaning you can start with AC mode by decreasing their rate, seeing how they do. Once you get to maybe 6, then either extubating, if you think they're doing well, by checking a blood gas first, okay? Or going to T-piece and then checking a blood gas. And that's okay, okay? If they're not, then go right back to their previous settings and give them time to rest. Revisit, see why is it that they're not extubated? Why can't they wean? What is it? What's the problem? And some patients may take longer, okay? If you decide to go, you're on the SIMV mode and you want to wean from there, well, you can come down on the rate first. If they're looking good and they're fine, then you can just make the rate 0 and start decreasing their pressure support. Once they're at a pressure support of 7 or less, and I don't go below 6 to overcome that just resistance of the ET tube, if they're looking good and you've corrected everything, they should be fine to extubate. Now, yes?
What would be in a respiratory rate that would not be acceptable to you? Their own respiratory rate?
Oh, if someone has a restrictive physiology, their rate is always going to be high if they have fibrotic lung disease. And the same thing with emphysema. So if you're looking at their rate, okay, and you want to know, is this an okay rate for them? You can do one of two things, and I would suggest doing both. One, check a blood gas. See, if they have CO2 retention, it may be normal for them. But if their pH is compensated, that's probably what they are, okay? Second, look at their work of breathing. In other words, are they just tachypnic, or are they tachypnic using accessory muscles and have paradoxical breathing? Two different things.
Yeah, we read for PSP trials, and we usually
Right.
write recommendations to stop the
Right.
trial if the respiratory rate is greater than 35.
Right.
That still seems like it will be too much for some.
It is, and I don't always, I don't do 35, but I give a rate, but what I do is I tell the respiratory therapist, look,
Just look at them.
if they're looking like they're using accessory muscles, they're paradoxical breathing, stop it and just go back. And that's why when you're doing this, I come back 2, 3, 4 times. You'll see my notes. I'm documenting every time I see the patient. Second hour of weaning trial, doing well, no paradoxical breathing, no use of accessory muscles, you know, and I'll document and keep documenting and keep documenting. You got to keep documenting, okay, what you're doing and why.
I think you've seen this patient on Saturday.
Oh.
This patient on 302 who extubated himself.
Oh,
That was the Benadryl toxicity. Do you remember that patient?
I don't think I did, but maybe I did.
Yeah,
Okay, go ahead. Uh-huh.
The fluid overload. The fluid.
Oh, yeah, the fluid oil. Okay, yeah.
Then I forgot to put the date.
Okay, yeah, the one. Okay, I got that now. Okay.
All right, so
Date and time, okay? My children, you know, just scream at me, but, you know,
Martin, the correct
so
put him on 260.
okay,
so
okay. Is that, yeah, I think that, might-
so my question is, he extubated himself at like
Yeah.
9:20 at night. I was on call that day. I called Dr. Crosland and I told him to put him on BiPAP, and he said, well, I'm not optimistic. You're probably going to end up intubated.
right.
So he
Based on what?
Well, based on he knows the patient.
Right, but retrospectively, why do you think the patient got reintubated? Maybe you don't know, I'll tell you. Okay,
well,
go ahead.
The patient had I just checked his X-ray. I think they said he had a severe pulmonary edema, all of that. But for me, it looked like more like an ARDS more
Well,
than anything else.
which is pulmonary edema. It just happens to be a non-cardiogenic. Okay.
So the
Why
patient
don't you-
was using his. Oh, you want me to
Go ahead, stop that for a second. Okay. The question is do I use BiPAP in patients who have just hypoxemia? No, you don't need BiPAP if they have just pure hypoxemia. Will I use it? Yes, I will, if I think they're developing auto-PEEP, even on a non-ventilator, because all patients who have asthma exacerbation have some auto-PEEP. I know I do when I get my asthma. And so I do it because I'm really trying to match their auto-PEEP. So by giving them a positive pressure, it's kind of a PEEP effect because it's continuous positive airway pressure, and it allows them to take deeper breath. Yes, I do.
We had a patient once in IMS, and we wanted him to rest on BiPAP
Right.
overnight. The RT,
Right.
the
Said no.
in charge, the
Right.
manager or
Right.
something, he said, "Do you know how much this costs? This costs
Right.
$1,000,
Right.
and we're gonna use it.
Right.
It's useless in
Right.
asthmatic patients."
Right.
So I just wanted to know whether
Right.
it's really helpful.
Okay, so does anyone have any questions about this lecture or the previous two lectures? I know we covered a lot, but I think with each lecture we have gone back and summarized what we discussed. And with each lecture, I think we've touched on some of the other things that we talked about. But I want you to approach it this way. I think if you do, it will allow you to retain what we talked about, and it'll allow you to feel better about what you're doing, okay? Again, the only way you're truly going to learn how to manage a ventilator and understand what it's about is by managing them. So there are ways to do it. And one way would be to, when you have a ventilator patient, take control over it, write down your thoughts, think about what we talked about. Why did they get intubated? What's their blood gas? What underlying physiology do they have? This is what I want to do today. I want to increase the rate. I want to increase the pressure support. How much? Why? Explain it. You don't have to actually do it, but when your attending comes by, you explain to them why you want to do it. And if you do that on a daily basis, it just becomes second nature, becomes second hand. Okay? So with that, any other questions? Yes?
One quick question. I mean, since
Mhm.
we have like 5 minutes or so.
Yeah, go ahead.
So you have a patient in the ER, he comes in for whatever reason it is, you decided, okay, you discussed the case, he needs to be intubated and put on ventilator.
Yeah.
I know we've gone through all of these things, but is there something, the respiratory therapist will come and tell you what settings you want
Right.
for this patient.
Right.
So we have to go back to all the calculations we've done. Right?
Well,
Or is there a set?
You're going to put everyone until you can sort it out on 100% FiO2, right? Because of what we talked about, making sure that they're not intubating one airway. So you want at least on 100%, that you've intubated them correctly, okay? So you start out with that. You should be able to either eyeball or know from the nurses what the weight is, so you can calculate the tidal volume, okay? And then based on whether you know why they're being intubated, you can decide whether they need PEEP or not PEEP, okay? And starting out at a rate of 12, like I said, because that's where we most of us breathe, right, at that point, okay? And then going from there, getting the blood gas and seeing what the blood gas shows, then you can determine, figure out what the rate should be, figure out what the tidal volume should be, and then you can determine whether you need PEEP or not based on do they have alveolar interstitial disease. If they have alveolar interstitial disease, PEEP applies. Okay?
And in terms of sedation, do we always need to sedate the patient?
No. If someone comes in and they're comatose, there's no reason to sedate them. On the contrary, you really don't want to sedate them because you want to see, are they going to wake up for you? I want to see them awake. Okay? I want to see them awake. Right, you don't have to. But if you have a patient who comes in with multilobar pneumonia, severe sepsis, the likelihood that they're going to get extubated in the next couple of days is not that high. So it is okay to give them sedation around the clock. They don't have to be on an infusion, okay? You can give them sedation. It doesn't even have to be with Ativan or Versed. It can be with Haldol. I like to use IV Haldol. With IV Haldol, there's less incidence of tardive dyskinesia. There's less incidence of some of the neural issues that we can get with oral Haldol. So, there's no set answer except if you can almost predict how long you think someone's going to be on the ventilator. Now, if they come in with an overdose, you don't want to sedate them. You want them to wake up on the ventilator. And once they wake up, you know you're going to be able to extubate them. And I showed you how I do it. I don't even wean. I just say extubate. Okay? Any other questions, comments from our young attendings? They've heard this lecture for, actually Dr. Lim could give the lecture. He's been here so long. He's known it for.
I'll just say, I hope you come back and give us the answers. Every time I hear it,
Yeah.
I learn something new.
Oh, good.
And I come up with a new question.
Well, coming from Dr. Ferlingos means a lot because, he was here as a resident, as an intern, then a chief resident now. So to hear that, I think is pretty significant. I will come back and I'll work with Samantha, this year's chief, and then next year with Manu to not only give this lecture, but also talk about x-rays again. And then I have a lecture on respiratory insufficiency, dyspnea and respiratory insufficiency, and then one on pulmonary function studies. So I hope this method helped demystify mechanical ventilation and give you a better understanding, but also give you some confidence, because that's what we all need. I can still remember the first time I really managed a patient on the ventilator by myself, how good I felt. And I hope that all of you can have that same kind of experience. Okay? All right, thank you. I think, let me see. Okay, good. You want to take some more photos because we've got two attendings here. Let's take a couple more photos. I want to get rid of Dr. Lim, and maybe you can disconnect me. No, we.
Let's take pictures. Let's take pictures.
Why don't you get your laptop?
He's allowed. He has allowed. I told Turi.
You want to go take a picture?
Got it? Are we all set? We take a little video?
We are.
Thanks.
Just don't worry about
The
it.
video?
Yes, you are.
No, you guys disappeared for like an hour.
Just